our Connections for Cardiovascular Health awardees have really brought their programs directly to their participants. Rather than requiring their participants to come to them, they have taken their programs literally sometimes on the road through mobile clinic vans directly to their patients, or by going to where their participants, where they are. So either going to barbershops or food banks. So during this session, we are pleased to hear from 3 of our grant awardees who are bringing their programs directly to their participants, where they live, where they work, and where they gather. We're going to learn about their programs, their effective practices, lessons learned, and some challenges that they have faced. We'll then have an open discussion with our panel and really kind of dive a little bit deeper into those challenges and how they have addressed some of them. So first, I'd like to introduce our panel. Sitting next to me is Dr. Jim Placetto, who will provide the viewpoint of the foundation. Then we have our first presenter is Dr. Teresa Tyson, who is the Executive Director, and Rachel Helton, the Director of Development at St. Mary's Health Science. They're going to be sharing their program, Expansion of Heart Health 123, Comprehensive Cardiovascular Disease Initiative for Diabetes Mellitus, Metabolic Syndrome, and Obesity Program, which is in Wise, Virginia. I'm pleased to say that St. Mary's Health Wagon has received an impressive 7 years of grant funding from the foundation. Next, we have Delane Hunter, who is President and CEO at North Georgia Healthcare Center in Ringgold, Georgia. She'll be telling us about their POWER program, the Patient Outreach with Education Resources program. North Georgia Healthcare Center has received also impressive 4 years of funding from the foundation. And our last presenter is Kathy Swenson. She's the Executive Director at Mercy Hospital Foundation, located in Buffalo, New York. She's going to be telling us about the Heart Smart for Life program. And Mercy Hospital Foundation has received 2 grants from the foundation. So first, I'd like to invite our first presenters up, Dr. Teresa Tyson and Rachel Helton, who will be talking about the Expansion of Heart Health program.
I'm sorry. For panelists, can you guys turn off your mics by clicking the button and then go through the description? We don't have.
So thank you very much. My name is Rachel Helton. Like she said, I'm the Director of Development with the Health Wagon. I'm going to have to get used to this clicker here. And I'm kind of tall, so I'm sorry I'm going to have to bend over. The Health Wagon is a mobile unit, like she said, but we are the free clinic that serves Lee, Wise, Scott County, Dickinson County, Buchanan, and Russell in the southwest part of Virginia. We're the only free safety net clinic that serves that service area. We have approximately, last year saw around 6,300 patients with over 12,000 encounters. We see a variety of patients. Our population is an indigent population that is uninsured. 98% of our patients are uninsured. We see underinsured patients, and we see underserved patients. This is Dr. Teresa Tyson. She is our executive director, but is also a family nurse practitioner. Okay, so talking about the cardiovascular need in Southwest Virginia, heart disease and stroke is the #1 killer of Virginians, according to the Virginia Department of Health. In our area, cardiovascular disease, diabetes, depression are around the top 3 diagnoses, most prevalent diseases that we see. Our life expectancy is decreased by 10.2 years, according to August Wallmeyer, who wrote the book Extremes of Virginia. Individuals age 65 and under are at risk of developing CVD as a result of the unhealthy lifestyles, inadequate food sources, the culture of Southwest Virginia. in our area, coal is a boom or bust industry, and right now it's a busted industry. So when coal mines shut down, actually our patient census increased. Coal miners began to come, and their families, children without insurance, no income. We don't have a public transportation system that is like many cities. You have to call 24 hours in advance to get a ride. The health need individuals with metabolic syndrome have a twofold increase in risk for heart attack or stroke and fivefold risk for a heart attack or stroke. So looking at the program goal, we were going to reach, our goal is to reach 5,000 participants and reach 1,000 and track them to identify individuals with metabolic syndrome, diabetes mellitus, and non-alcoholic fatty liver disease, and correlate the risk for CVD related to the afflictions, ultimately minimizing and preventing the risk of a cardiac event through health education, the diabetes prevention program. We've got 3 folks who are on staff that are lifestyle coaches for that program. And we're actually working in partnership with a variety of different organizations who are doing innovative things like providing food for participants. We spoke about incentives this morning. The clinical approach is intensive diabetes management, glucose monitoring, lipid management, hypertension management, ultrasounds, behavioral things like food and exercise education, lifestyle coaching, with the diabetes prevention program, lifestyle coaches. And behind our facility at the Smitty Clinic in Wise, Virginia, we've worked with Novo Nordisk to get a community walking trail. So if patients are interested, we have a community garden in the back and then a walking trail that surrounds that. Our dissemination plan, we're currently developing our toolkit. It's going to be developed. We're working with a student locally from GMEC who is applying to medical school, and it's going to be published in our annual report. We're going to distribute that to healthcare organizations, community-based organizations, faith-based organizations, local providers. Someone mentioned earlier about health systems working in silos, and you really, to have a healthy community, you need to work together. So that is one of our goals in Wise County, Dickinson, Buchanan, our service area, is to really eliminate those silos to work on those diagnoses.
The average blood pressure, we've seen really significant progress with these numbers that we have. The average blood pressure is 139/74, and the total cholesterol is 195. Our hemoglobin A1C is 6.8, which is exceptional. Our weight, 40% have reported decreases in weight, which is really phenomenal. And you really don't expect to see these type of numbers, but we're seeing these, and we're so very happy. We also work with, in a partnership with the local hospitals, doing a CareScope 360 grant. That's where we take the uninsured self-paid patients that are frequent utilizers that are going into the emergency rooms there and very frequently, and we're working with them to decrease the amount of hospitalizations and taking them and getting them some very coordinated care, and that has worked out really well in a partnership with the hospital. But we're identifying ways to increase, like the physical activity, you know, decreasing we live in a population where smoking is high rates of smoking and tobacco use, and we're seeing decreased rates in that. With our sustainability, I mean, we're always looking, you know, at partners with others people on individuals on grants, other programs, corporations, individuals, foundations. We're always working that, private donors, legacy giving is a new aspect that we're approaching as well. And one of the things that we're trying to do in our area, because we live in a very beautiful part of the country there in the Central Appalachian Mountains, and we're trying to promote medical tourism. Historically, we've had a lot of poverty, but on the other hand, it is a very beautiful, it's one of the prettiest parts of the country that you'd ever seen. So we're trying to promote like the medical tourism, and we've got that on our website. And that's been very beneficial because we'll get some people that want to come, and they'll come and spend a week with us, and they will come in and, see the patients through the week, and maybe at the end of the week, we'll get them out into the community, and Rachel takes them four-wheeling and things like that, so that's worked really good. Very proud of, some of our dissemination plans here. We've been blessed to be on the 60 Minutes, as I was telling people in our group a couple of years ago, and they've actually rerun that 4 times for us. And with that, we've gotten a lot of opportunities to come and say, would you come to this conference and speak and things like that. And so part of that, telling about the health wagon and the services that we're offering, we're also showcasing one of our, like AZHCF Healthcare Foundation, who is a wonderful partner, because we do not do this in isolation. And, AZHCF Healthcare Foundation, like everybody in this room, is on the front runs with us, saving those lives. So we've been able to present at the United Nations, the World Health Organization. Tomorrow we're presenting at the Nurse Practitioner AAMP Winter Conference tomorrow. And we just, last week we presented the Celebration of Rural Nursing in North Carolina, and it was a simulcast that went to, I think, 6 other colleges there in North Carolina. We've also presented at the Lions Club as well. So we're always looking at ways to get that out. And as Rachel said, we're also working on the toolkit. The challenges that we have are probably like others in this room. I mean, we have poor health statuses. We've got, certain health care disparities. As Rachel was saying, our people, they live 10 years less than our counterparts that live on the Eastern Shore. And some even say it's as many as 20 years less. We have increasing elderly population. We have, like a transportation, as she was talking about. We have economic disparity that's inherent in the area, lots of chronic poverty, high rates of employment, low levels of education with our literacy rates. Just have a lot of lack of healthcare resources, and we're a limited resource area, so we've got to look outside our area to bring things in. And one of the things that we get resourceful about is with our mobile unit, and we find that an innovative way because we're taking healthcare out to the community. And we use state-of-the-art telehealth in our area that has been very, very well received. We're able to bring, in the case of like this grant, we're able to give our patients access to cardiologists, endocrinology, and it's something that we don't even have like in our immediate area. The lessons learned are that we really think if you work to remove the barriers for these populations, for diabetics, for instance, it's not that they don't want to take care of themselves oftentimes. They often don't have the resources. They have, we get them the glucometer strips, we get their endocrinology visit. If they're hard to control diabetic, we get them the medications through the patient assistance programs. We get their labs for them. And so once we kind of remove those barriers, then it goes really well for our patients, and we have improved healthcare outcomes. Lack of access to health care, for the first time ever, we're having people put patients on a waiting list at our clinic, and we have lacks of subspecialties and specialties, as I was talking about, but we're trying to overcome that barrier. Going on down, because I think our time is running short here, one of the things that I think that we're looking at is trauma-informed care. I mean, when you live in these very impoverished areas and things like that, there's a risk associated with trauma, and it actually affects when people as children are exposed to things like emotional abuse, physical abuse, substance use in the family, and things like that, chronic poverty and things like that. It actually shortens it not only changes the DNA that we're thinking, but it shortens their lifespan by 20 years. And so I think that is one of the things, the current challenge that we're looking at is dealing with this population. And I guess looking at it in retrospect, what happened in childhood and early adulthood that actually makes this population, it affects like the cardiovascular disease and things like that. So that's one of the things that we're looking at. Thank you. Thank you so much. Thank you so much, Teresa and Rachel. It really is really nice to hear all the great work you're doing in your community. Our next presenter is bringing their program directly to participants in Ringgold, Georgia. Please welcome Delane Hunter, who is here to tell us about the POWER program.
The name name of our program is the POWER program, Patient Outreach with Educational Resources. Our facility has about 4,800 patients that we serve with about 12,000 visits annually. However, with this particular program, that doesn't always include everybody that we've gone out because they're not necessarily a patient of ours. The cardiovascular need in our particular area, meaning the state of Georgia, that's where we can get our numbers from, is about 10% of residents have diabetes, and about 32% of Georgia deaths are CVD related. We don't have specifics right around where we are. We can only get overview, but when you look at the map of Georgia, our area is in the red, and what that means is that we have an excessive amount of that 32%. So our facility early on looked at that ratio and knew that there was a CVD and a diabetes issue in our area. And so our program goal was to provide testing, education, and resources to prevent, diagnose, and treat high blood pressure, body mass index issues, obesity, and heart disease among the underserved and vulnerable residents of our community. So our facility is a nonprofit facility. We do serve underserved and private pay. Private pay also means underserved because they're in that loop of not having insurance as well. So in our program, we wanted to make sure that it wasn't just about those with the disease, but also being able to do preventive measures before they get to that place. Our program approach initially, and we talked about a little bit about this earlier, we had, we thought, okay, we can do this. We had high numbers, that we submitted, and we did realize that, yes, we ended up completing our goals and doing very, very well, but it is about the goal of actually making a difference and concentrating on individuals. And so while we started off with that, the information that I'm going to give you is really about our third year of funding that we received because we reduced our numbers as we went along, and we were able to just build those relationships with our program participants and utilize our staff. Our staff actually, and we use different staff for this, but we go out on site. We go out to the YMCA. Actually, when I heard you were from the Y, I was like, yes, because the Y is a huge partner of ours, both in the field and at our facility. We have aquatics. We have an indoor pool, and they come and do our aquatics program that has been a part of the AstraZeneca program for our exercise, as well as us going out to their locations. They were already in the community, going to churches, going to the senior center, those types of facilities. So we collaborated together in order for us to bring our program to who they were already seeing with the exercise. And so it was just a collaborative effort on going out into our community to be able to serve the most underserved where they also can't come to us. So it was just a perfect opportunity for us for that. When we go out on site to perform labs. We do pulmonary function tests. We do vision tests. We do multiple. We don't do EKGs on site, but we perform those and then actually bring those participants into our program. And because we're going to the same locations where they're having their programs, we are able to track those participants that are actually out in the community as well as our patients, because our combined effort is between patients and community members. what we try to do is, I'm not using anything, I'm just talking. We want to make sure that we do a 3-month effort, especially on lab work, so that we are doing surveys at that time, because initially we get what their education level is on CVD, an initial baseline of that, so that we can also track how much they have been educated throughout this whole process. So we're doing lab work, health checks, and so forth. So we do that in-house as well as on-site. One of the locations that we go to is a school, and so we have been able to go out to that school multiple times, and when we do pulmonary function and we do some of these screenings, we have been able to make an impact on what we think as preventive on younger children, because we've had like 6 children, and I say children, they're youth in their high school age, but we have made an impact on them of stopping smoking and some other things, because we give them a young age, and there's just different things that we have implemented with this program that's made an impact on what we do in the field. As I said, I used the last full year of funding for this, where we tracked 500 patients. The total grant years to date, we have tracked 2,325, and we've done a reach that year of 5,000 community members. Now, the reason those numbers are so high is that we do a lot of community events where we will go out and talk to. There's a big J-Fest where we are. There's also a lot of local events, so we are promoting this program whenever we're there as well. For clinical, we reduced the average weight by 28 pounds from an average baseline of 236 pounds down to 208. For our A1C, there was initial baseline average of 8, and we were able, through this program, to reduce that by 2 points on those individuals as a whole. For behavioral health, whenever we did our surveys on their baseline, it was 68% of knowledge, and we were able to, in the end, increase that to 89%. For the initial average of exercise, it was 70%. Now, this was their knowledge, not necessarily what they do, but their knowledge was 70%, and we increased that with the education up to 87%. Average knowledge of nutrition and healthy eating was 68%, and we were able to bring that up to 90%. The sustainability and dissemination, I have done multiple things in the community with local lead groups, through the chamber, and with we're compiling a mailing right now where we will have this program and be utilizing that effort to do that. And we got some good ideas today on some of the things I think that between the three of us, that we took a lot of notes, but we feel like we're a little bit behind on that, and in getting out other than locally on some of the places that the events that we've done and so forth. So we want to really make a conscious effort to go a little bit broader on that, and a little more creative. So I think we're going to be using some of those funds to use outside sources in order to do some dissemination. We also submit for grant funding in order to sustain as well. The challenges that we've had are the same. From what I hear, we are bringing programs to the patient with consistent attendance, but keeping patients in compliance with what we're asking them to do medically. And then the number of participants, I've already discussed, and kind of lowered that, where we felt like that we would be able to handle that a little bit better and have a bigger impact. So the social media, and we have used that to also provide information about our program, where we continue to present our program at local events and communication. Lessons learned are patient education materials, and that all not individuals are passionate, but we're there to give them that passion and help them with that. And then the current challenges, all three of those are the same. We have used telemed, and some of those challenges are some of those specialists do not take insurance, and they won't, or take insurance, but they will not take underserved. So we're working through those challenges right now on being able to work with them on some specialty cardiovascular appointments and things. Thank you.
And people are reacting to that. Thanks, Elaine. It's really great to see it. It's very great skill to work with doing in Georgia. Our final presenter is Kathy Swenson, who is bringing her program directly to her community through a mobile clinic and through community partnerships. Here's to present on her program, on the program Heart Smart for Life.
Well, good afternoon, friends. I'm Kathy Swenson, the Executive Director of the Mercy Hospital Foundation, and it's my pleasure to tell you a little bit more about our program called Heart Smart for Life. But before I tell you about our actual program, I'd like to tell you a little bit more about our community and make sure we're caught up on our PowerPoint as well. Thank you. There we go. I think we went one too many. There we go. Okay, now we're caught up. Has anyone heard of the chicken wing? Yes, everyone's heard of the chicken wing. I don't mean to pick on the chicken wing today. I keep saying that. But I do want to point out we've got some food issues in our community, which I know many of you also share as well, which may lead to some other more significant and more important issues in our community. In Buffalo and Western New York, we lose more of our friends, family, and loved ones to heart attack, heart disease, heart failure than any other cause of death. Anybody else in this room, can you relate to that statement? Quick raise of hands. Yeah, it's something we're all dealing with. At the Mercy Comprehensive Care Center, where our Heart Smart for Life program is housed, it's in the 14204 zip code of Buffalo. Almost half the people, 48.5% of those living in that area are living in poverty. And Buffalo is the third poorest city in our nation. And we all know where there's poverty, there are healthcare disparities and elevated risk factors. Heart Smart for Life's goal is to use a multidisciplinary team approach to help the poor, the vulnerable, the racially diverse in this area, specifically of Buffalo, to overcome the many health barriers that they face. And we're doing this with trying to meet the people where they are outside of our clinic walls. We're taking our care to them, connecting and then creating a very non-judgmental environment where they can feel safe. And I know many of you are doing the same things with your programs. Oh, I think I did it again. One too many. Let me read that for a second. Yes, okay, there we go. Our program has been graciously funded by the AstraZeneca Healthcare Foundation since 2016, and we officially launched this program in just January 2017. So since launching it, we've reached over 800 people, and we're currently tracking 190 patients and participants. In year 2 of our funding, 2017, our goal is to reach 600 people and track 150 patients. At the end of September, we had reached almost 300 people. That's 3 times our goal for that first 3 months of that program year. And we're tracking about 31 new patients with elevated risk factors. It's a program with real results, real momentum. So the question is, how are we all going to keep these programs going, right? Well, by sharing our case for support and the data that we're collecting for the AstraZeneca Healthcare Foundation with potential local funder partners. We're also sharing our program with other providers at doctor-to-doctor events and healthcare forums in our community like the P2 Health Collaborative as well. And we've created Heart Smart for Life patient-focused and physician-focused videos and pamphlets to share our champions and their successes, to recruit more patients, to secure more program partners, and to inform more physicians about what we're trying to accomplish in the community. I'm going to try to go one more. Yes, go right ahead if you don't mind. Thank you. And like many of you, we face challenges. And one of our primary challenges is consistent participation and compliance. Anybody else have this on your list as far as a challenge you're facing? We're working with a hard-to-serve population with a number of challenges, and quite frankly, sometimes their own health is not their top priority. So we have to be creative, right? We all have to be creative. We have to offer incentives for continued success. Heart Smart for Life has helped us recognize that our health center also was not reaching the community right outside of our own doors. We discovered that our own patient ranks were about 15% African American, when our community right outside our doors was 74% African Americans. So Heart Smart for Life is helping us balance the demographics of the people that we serve as well. Our partnerships with local schools, community centers has helped us reach a more diverse population. We're working to overcome our compliance challenges by empowering tracked participants and patients to create their own SMART goals for the Heart Smart for Life program, or specific, measurable, achievable, and results-targeted goals. It's their goals that they identify for themselves, and that they create their own personalized visioning boards so they empower themselves in their own program. We're encouraging our participants to arrive on time by offering incentives to those who are in their seats no more than 15 minutes after the start time. That's another way we're getting them in the door, getting them there on time. And we're advertising our class topics in advance so that the participants can decide, does this topic meet my health goals and my needs? One more slide for you. Thank you so much. So in closing, what have we learned? Well, number one, community partners are absolutely essential for success. Creating a safe, judgment-free environment is critical for participation and patients to feel comfortable in your program. And we all need incentives to achieve real results. We're going to continue to work on recruitment because, quite frankly, we know that lives in our community are depending on it. We're going to strive to keep our curriculum fresh and relevant. And last, but certainly not least, we're going to continue to break down our own walls and expand our partnership to reach people where they are in our community. Thank you.
I think maybe at this time we can all turn our mics. Thank you all for telling us about your programs. During each of your presentations, you all mentioned some of the challenges, and I see some people nodding in the audience as well, that each of your programs have faced, and started talking about how you were working to address them. So I thought we could take the next 15 minutes just to kind of dive deeper into the challenges that you mentioned and hear really some more of your insights about them. Given the population that you all serve, so we're talking about the underserved population, it was very clear to me that a lot of your programs will help about diabetes, cardiovascular disease, abuse, high blood pressure, obesity. So how do your programs work with participants who are struggling with these multiple conditions?
Well, I can answer for the Heart Smart for Life program. It's one of the things that we have identified and heard back from some of our participants, that they've come to us because perhaps they were identified by their physician or referred even at an event where they connected with us. But they come to us and then they say, you know, I'm really struggling with diabetes, or I have a family member who is, and I'm trying to also share this information with them. So we have really adjusted the curriculum. And we have a dietitian that works with us as part of the program, and she has adjusted the curriculum to also make sure that we're meeting all of those different comorbidities and those different issues in the community. We actually had our own stroke care program and providers come to us and say, we know it's the Heart Smart program, but we have problems, obviously, with a lot of our stroke patients, and we think they can learn a lot from you guys. So we've also adjusted the curriculum in that regard, because we all know it's all really one big system. And people who can benefit from learning how to eat right, be more active, be more healthy in their lifestyle, whether it's cardiovascular disease, whether it's stroke, whether it's diabetes, the program's trying to meet their needs where they are.
To throw my 2 cents in from the Health Wagons standpoint, one of the events, she mentioned large outreach events. One of the events that we spearheaded over 18 years ago was RAM, Remote Area Medical. So each July, we have over 3,000 patients who come during a 2-day period to receive medical, dental, and optometry services. And most of our patients are train wrecks when they get to us. They're uninsured, they're at death's door, they have multiple chronic illnesses. It is not uncharacteristic for us to see patients with multiple chronic illnesses. Mm-hmm. So, and it's sad because the RAM event is actually some people's 1-year checkup. They'll come and camp out and hope to get a ticket, and we hope to serve them. So we've got 2 stationary clinics and 2 mobile units to do everything that we could possibly do.
Thank you. We also talked about, and it's a good follow-on to Kathy's presentation about the incentives, right? So we've also talked about, some of the challenges about having the patients come back to the program and return to follow-up appointments and to receive those necessary services and to make sure that they're assessed for improvement. What other strategies, I know we've heard about the incentives, but what other strategies do the other programs utilize to really help encourage those participants to come back for these follow-up appointments? One of the things that we've done at the Health Wagon is that we use, I think we try to find any resource that we can, because we're in a resource poor area, and we throw that at the patient. I mean, really, we use our pharmacy students. They will go in because transportation is a real issue, so it's not always possible for them to, to get to the clinic. And so we use our students to call and, for our diabetics, for example, and, make adjustments and work with them closely on a one-on-one more relationship. And so we're just looking for any and all resources that we can, for our clinic there, because we are a low resource area. So you'll have people call to remind them to come back in? Mm-hmm. Yes, our students, our pharmacy students, and they're working. Most of their preceptors are certified diabetes educators. They'll do lipid clinics for us. So, cardiovascular, we've got cardiologists that will volunteer and come in. We've got, we can provide with cardiologists over telehealth. Any resource that we can find. I mean, that seems to be working for us. And God has provided us with a lot of good resources, fortunately.
And we have a designated individual that makes phone calls if we see we need something from someone. Either they didn't get it while they were there for a visit, or if we're in the field and we get results for something and see that we need something, then we make that personal connection with them and get them in.
One of the things that we heard this morning, and one of the things that we see from across multiple programs is, obviously incentives is a great tool, and there's all different types of incentives, but another is that the ability to break down barriers that the participants might have. If they lack child care, if it's a situation where, they work at certain hours, and, one of our programs actually tailored the time of when they would go out, again, same theme, go out to meet with the participants. It would be at the end of the day. They were farmers, and they worked until dark, so it didn't make sense to have the program at 6 o'clock, but they found it. So, the whole concept of, what are the barriers that might prevent them from being there, and can you break the barriers down with some sort of approach? I mean, obviously transportation is one where you bring it to them, but there are other barriers to solve.
Does anyone in the audience have anything else that they have found to be effective or really making sure that we're working on compliance? That's okay if you don't. I think those are a lot of really great ideas, and I like the developing these personal connections really, because I think it provides them with even more incentive that's not tangible, right, to come back because somebody else is really out there caring for them and really concerned about them. So I thought that was good as well. Well, speaking of which, we know it's important to educate participants, but I think to have some really long-term changes, it's equally important to really empower them to take charge of their own health. And I know several of you mentioned that that's one of the problems, right? It's giving them the empowerment and accountability to take charge of these actions and following up with them. So can you tell us about some strategies that you are using to empower your participants to really feel empowered?
One of the strategies that we're taking that I talked a little bit about in our presentation is really they're creating their own goals. They're coming to us and saying, you know what, this is what I want to do. This is the step I think that's very important for me. One of our champions that I know you'll hear from tomorrow in our video, she came to us and said one of her health goals was actually to get her confidence back. She had lost her confidence. She had suffered 2 strokes in less than 2 months. She really thought that was it. She thought that was going to be the end of her life. And she said it just rocked her world. And as we all know, when you suffer something like that, so catastrophic, so life-changing, it can really affect every part of your being, including your self-confidence. And she identified and said, I want to be able to get my confidence back. I want to start sharing my story in a way to inspire others. So we invited her to one of our leadership meetings with the Mercy Hospital Foundation. And she came and she spoke and she sat with Jeannie, my colleague who's here with me, and as they talked about their program, and she talked about the impact that it's had on her, and she talked about her weight loss. And being able to do that for her, it was a self-identified goal, not a larger goal of our program, but it helped her because it was an empowerment issue for her. And that's kept her coming back and built her self-esteem, and she's just done great.
I think from the Health Wagon, one of the best ways is to just communicate to patients, and our patients' literacy rates, unemployment, low education, our providers take the time that a typical physician wouldn't take to explain. They may not understand cardiovascular, but they understand that they've got heart disease. So simplify it for them and get with them and communicate with them so that they can do something about it. Self-efficacy is something everybody wants from patients, but you've got to explain so that they understand.
We're also working right now. We're getting ready to do some group things where they will have encouragement with others of with the same issues and so forth. So we just now have some individuals within our center where we're able to do that. They have the knowledge and education for that. So that's one of my goals for this next little bit, is to get those I don't want to call them classes, really group sessions of with individuals that can come together.
Supporting each other.
Yeah, the concept of that peer-to-peer interaction, we see a lot, and it's very, very effective because there's a trust factor that's there. It's not necessarily the medical intermediary, but it's someone that they can connect with, and it really kind of empowers the full group when there's that peer-to-peer interaction. So I think that that's a great strategy from a standpoint of really working with empowerment.
Thank you for sharing. We've often talked about patient recruitment, and we know that it's really truly an ongoing process throughout the entire year. And sometimes participants will drop out over time and drop out of the program or sessions. What processes have your programs put into place to ensure ongoing recruitment of a program throughout the grant year?
We're constantly looking for new community partners and working with, whether it's our community centers, whether it's the schools, if it's even the grocery store. because where our Mercy Comprehensive Care Center is located is actually 3 miles from the nearest grocery store. So it's considered a food desert right in the middle of the city. And working with those partners has helped us reach people in the community that we were not reaching before, that we're not making that step to walk through our door and come to us. So it was a chance for us to get to them, recruit more patients, and then connect with the right people in our community as well. I heard some great ideas, though, as far as patient recruitment right here in this gathering with AstraZeneca Healthcare Foundation. And I just want to thank some of you folks for sharing that as well. The idea of asking your own participants, where should we go to connect to people? It wasn't something, honestly, that we thought to do. It wasn't one of those questions on the survey before, but just hearing that feedback has given us some ideas as well as to how to connect with them. The other thing I heard from some participants in our roundtable discussions earlier that really inspired me was the idea of the participants actually assisting, not only being champions of the program, but being sort of champions in that they're helping collect the data. Maybe they're taking the blood pressure. Maybe they're checking with each other on their blood pressure numbers. And so it's not just the RN that they're checking in with every time they come in for a class, or the social worker that they're talking to, or the nutritionist, but peer-to-peer, and working that way as well. So then we can connect perhaps the champions with the other patients and participants. And I think that's a great way to continue that word of mouth and that recruitment.
Does anyone else have any ideas?
I think one of the biggest things you can do for your patients is help them with medications. And in our area, we are part of the Pharmacy Connect program, which is one software program that connects patients to patient indigent programs for medicine. So in our situation, patients are going to continue to come to us because we get their medicine for them. Mm-hmm. And it seems to work.
And I really like that idea, because who knows better where the participants work, live, and gather than the participants themselves. I think that it might seem obvious to you now, but
right?
Really
it's a little bit of a no-brainer, but
I think for us with our clinic situation, just because we have our number of tracks doesn't mean that we're not. We're doing some software things right now where we're going to be able to pull specialty different things and so forth. So it's not just stopping because we have, hey, we've met our goal with this certain thing. It's everybody in that criteria and bringing those individuals into those groups as well. So it's recruiting from what you have and be able to utilize that as well.
I'm sorry, go ahead.
Some health clinic partners that we work with do some of these wraparound services, and they also register some patients for health insurance through the Affordable Care Act. Do you all, I mean, does that help you all with funding? How does that work with you all as a clinic? Do you also include that registration so they can receive health insurance?
Yes, we have a navigator that is within our facility. She is also not just physically in our facility, but she is out at community events as well. When we have one, she is there. She also goes multiple, like she's at the library, she's at multiple areas in the different counties even. So we do have a navigator.
I think, unfortunately, for the health wagon, our patients, the Affordable Care Act, I can really not tell you maybe a couple of patients that were able to continue on with the Affordable Care Act because we just do not have, wage-sustaining jobs to support those monthly premiums. You would think that our patient population, it would benefit the most, but it has not. Now, if in Virginia was a state that did not expand Medicaid, if we'd expanded Medicaid, that would probably help, but that didn't happen in Virginia.
And we don't do any billing. We're completely sustained by foundations, grants, private donations, and giving, legacy giving.
A lot of you guys talked about the importance about community partnerships right? And you're not out there doing it alone. You really are working with the broader community to get everybody the support that they need. For some of these new organizations who might be doing remotely or otherwise, who are just kind of trying to get their program up and off the ground, do you have any advice for them about really how do you go out and start partnering with some of these really great organizations within your own community?
I think one good suggestion is to have health fairs. I mean, because we actually started health fairs. I've been there for 25 years now, and we actually started out with just small community health fairs, and that developed into the very large, the largest medical outreach in the United States, the RAM that we were talking about. And I mean, we have over 1,400 volunteers at that event, and a lot of them, they don't only come to that event. I mean, they come back. They'll say, I'll be back in 3 months. I'm a cardiologist. I'll see patients, and we'll have them on a waiting list, or I'm a nephrologist or things like that. And then the resources have just really bloomed out of that. But we actually started with just small community health fairs, inviting everybody that wanted to come and participate in that. And then the resources have just, if we did one thing right, it was starting like community health fairs involving lots of stakeholders, because we cannot do it in isolation.
I think for us,
oh, I'm sorry, go right ahead.
I was just going to say, I think for us, it's also looking at who you may already partner with on other things, and really looking at what your goals are, and when they align, moving out to other things. So that's what we were able to do, partner with them on what they were doing, and then they were partnering with us as well.
We started attending health fairs, not necessarily hosting them, but looking for them in our community, whether it was at a school, whether it was at a community center, or whether it was another group of community health providers, and then going to those health fairs and talking to people about the goals that we had for the program and what we wanted to achieve and who we wanted to reach and why, and those partnerships started to form from there. I would say the other way that our partnerships started to form was just looking around our community itself and saying, what makes sense? Who's nearby? What makes sense? And where are the gaps that we know exist within our own service plan and our program, and how might we be able to partner? We wouldn't necessarily have met up with our local grocery store and brought them down into the center at a health fair, but it was a natural fit to bring them in, because otherwise most of our patients, our families, were shopping at the gas station with a Family Dollar, and they're not getting fresh fruits and vegetables and things like that. So we wanted to bring them in. So that was another way. We just looked in the community and said, who do we need to bring in, and who's the right fit partner for us?
And how would you go about, you mentioned you might identify a gap, right? So something that your program's not providing, but that you know that your participants may need within your community. How do you go about identifying those gaps?
I was really talking to the participants and saying to them, where are you shopping? Tell me a little bit about your eating habits. And when we talked to them simply about reading the labels and understanding good nutrition, we were getting questions back like, what's a carb? There was literally very basic food understanding that was missing. So we said, okay, that's a component that we realize we need to bring to these participants, because it's such a vital component to your health. And so it was really talking to the participants about what brought them to the program in the first place, and then realizing where there was a gap in their understanding or their connection in the community, and trying to build the partnerships that they needed.
At the Health Wagon, we partner with a local school, University of Virginia's College at Wise, and we're constantly doing community needs assessments and economic impact studies of events. And if you can keep up with your needs assessments, you can really identify which grants can fund your innovative ideas to fill those gaps.
We did a Give Back Day, and we brought multiple, and not necessarily all of them were partners, but multiple organizations in the community together on one day, and had a community event so that they could come, and whatever resource they needed, that they might be able to get at least connection on that day as well.
We heard earlier today from Gopal, again, with the theme of what we're trying to propagate here is, I think it's a critical that in any opportunity that you have to disseminate the great outcomes you have and the results and the impact that you're making in your community will by just by the sheer vision of what what other organizations are seeing or doing will be able to open doors. I mean, that's part of what we think, and we're hoping out of the dissemination efforts as part of the sustainability, that just the ability to have your information out there, whatever form it might be, is hopefully will open other doors.
Yeah, that was what I was going to say as well. It seems like this all ties in quite nicely with all of our other learning laboratories today, right? So how do you tell your story that's in a compelling, effective way that's going to bring on board other potential partners, not just in the recruiting of your participants, but really how do you get that message across to really get other people inspired to come out and volunteer, right? The doctors, the cardiologists you met at these community health fairs. I think that's really great. I think we have some time now to open this up to any questions. So if you have a question, please raise your hand and we'll. Any questions? Do we have anything from our remote cast? Well, if there's no questions, then we can give you back some time in your day. I think this was a really, really great session, and I want to thank each of you for coming and presenting today. You've mentioned and really highlighted a lot of barriers that your participants face, lack of transportation, geographic isolation, poverty. Surprised to hear lack of transportation where you have to give 24 hours notice in order to get a ride. So it really highlights for me and hopefully for others the importance of having programs like yours that are really tailored to the unique needs of your communities. So thank you so much for all of that, and really I wish you all the luck for continued success for all of your programs. So thanks again.
Thank you. Thank you.